So at the end of the day, we're kind of arguing about very marginal differences in survival improvement with any of these treatments. We certainly know that survival with surgery alone for esophageal and GE junctions is poor, generally less than 20 to 40%. The accepted strategies have been preoperative chemotherapy alone or combined chemoradiation, which is the most common US practice. And again, the survival improvements over surgery alone that are achieved are fairly marginal, anywhere from as low as 6% to 14%. And indeed, one of the studies that Eric quoted, the OEO2 study, which sort of set the bar for preoperative chemotherapy, was arguably a failed trial with only a 6% survival benefit. And that prompted further evaluation of preoperative chemotherapy in the UK, which we'll talk about. Why should we include radiation? We want to enhance the rate of R0 resection. If you do not achieve an R0 resection, you die of your cancer. So that's the bottom line. So, and when we see some of the really poor rates of R0 resection in large contemporary studies with chemotherapy alone, to me it argues that radiation is needed depending on the anatomic site of the cancer. And we also want to enhance the rate of pathologic complete response, although I'll show you rather provocative data that it may be more important to have an N0 status, that path CR may not drive the bus, but that we need to get patients node negative. So rather than sort of go through individual trials, I've sort of summarized all of them, all of the contemporary trials, to really look at these outcomes. So what about R0 resection rate? So OEO5 was a study that, again, the British trial, that 6% survival, inspired them to do a 900-patient trial and their old standard was 2 cycles of platinum 5-FU, and they thought more chemotherapy and adding upirubicin would add a benefit, and it really didn't. But look at these rates of R0 resection. So this is 900 patients, endoscopic ultrasound staged, half of them had PET scans and laparoscopies. This is 20 years after platinum 5-FU, and they still get R0 resection rates of 60%. So I've challenged them at many international meetings. How can you call this an acceptable preoperative strategy when 30 to 40% of your patients can't get a curative resection? So then they did a similar trial in gastric, but on this gastric trial, this was a ECF versus CF question, and ECF was no better. So, and remember I told you that CF times 2 was a failed strategy, so you could even argue, since ECF is no better, that ECF is a failed strategy in esophagus also. So if we're comparing FLOT versus ECF, maybe we're comparing nothing versus a slightly better chemotherapy. So STO3, this was a bevacizumab question, a perioperative ECX with or without bevacizumab. This was a 1,000-patient trial, but 2/3 of the patients had GE junction cancers, and look, 69%. So this is nearly 1,600 patients that they put on these studies, where 30 to 40% of the patients were doomed to death because they couldn't get an R0 resection. So now we have the FLOT data. Now, one of the problems with the FLOT data is this is gastric and GE junction cancer, and I think Eric, you actually conceded the debate when you showed that the survival with cross was the same as the survival with FLOT at 3 years, but half of the patients on the FLOT trial had gastric cancer. They do better. Gastric cancer patients do better, and only half had GE junction cancers. So if you achieve just equivalent survival with FLOT versus cross, and you've got better prognosis gastric cancer patients on the study, then that doesn't really make the argument that FLOT is better. But FLOT absolutely, I think, killed off ECF. And actually, nobody should give ECF any longer as a perioperative treatment. If you're going to give patients for gastric cancer perioperative chemotherapy, it should be FLOT. But only 400 patients on the FLOT regimen actually had GE junction cancer. So this is a lot smaller number compared to the 1,700 patients here. But you did get an improvement in R0 resection with FLOT, but again, this included gastric cancer as well. And then the cross trial, you got more than a 20% improvement in R0 resection with surgery alone over chemoradiation. So now, what if we look at the subset? So does it make a difference where the cancer is? And to me, this also wins the debate. this is STO3, so this was a gastric GE junction cancer where everybody got perioperative chemotherapy with or without bevacizumab. And if you were a stomach cancer, you did fine. So 87%, this looks like FLOT, but look what happens when you move up to the esophagus. So again, esophageal tumors, 66%, Siewert 1, 61%, Siewert 2, 72%. So if you're a more proximal GE junction or esophagus cancer with chemotherapy alone, these rates of R0 resection are unacceptable. And if you're a stomach cancer, you do okay, 87%. If you're a stomach cancer, get preoperative chemotherapy. If you're higher up, you need to get radiation. And the FLOT trial does not answer that question. Trying to move it forward. So what about PathCR? That's another holy grail. Is PathCR better with chemotherapy or chemoradiation? So it's pretty poor for ECF, single-digit percentages. FLOT was better, 16 versus 6%. Chemoradiation consistently better than chemotherapy alone, 16 versus 2%. And in the cross trial, the adenocarcinoma patients, it was 23%. So what about overall survival? Again, this OE05 trial, ECF was no better than CF. And remember, CF from that earlier trial achieved a 6% survival benefit. So arguably, ECF no better than platinum 5-FU. STO3, now here you see, because half of the patients had gastric cancer, the survival was better than this purely esophageal cancer study. FLOT, you got a 9% improvement in survival, so clearly FLOT, no debate, better than ECF for gastric cancer, but this is a mixture of GE junction gastric cancers. And if we look at chemoradiation versus chemo, Eric called this a trend, but it was a 20% improvement in survival favoring chemoradiation over chemotherapy alone. It's a pretty not significant 20%. I mean, you could put your fist between those survival curves. And then Cross, of course, did show a modest survival benefit, 10% for chemoradiation over surgery. So why include radiation? I think we have, I'm very troubled by the British data in 1,700 patients. If you give chemotherapy alone, your R0 resection rate is 60%. It goes up to 90% if you give chemoradiation. So higher rates of R0 resection, potentially higher rates of PathCR. But that being said, FLOT is clearly superior to CF or ECX in both of these endpoints. So why else include radiation? Two other points I want to discuss is local recurrence and enhancing N0 status. So local failure, these contemporary trials, they're kind of early on in reporting. OE05, which was ECX versus CF, only reported about a 10% local failure rate. However, if we FLOT, it's not reported yet, it's too early. But if we look at the chemoradiation trials, POET compared chemoradiation versus chemotherapy alone, and you had a 20% reduction in local recurrence. On the FLOT trial, on the cross trial, a 20% reduction in local recurrence over surgery alone. So a suggestion that adding radiation improves reduces local recurrence compared to chemotherapy alone. And this, again, it's a trend, but suggests that you get better local control with chemoradiation compared to preoperative chemotherapy. Now, what about N0 status? So in the British studies, only about 30 to 40% of patients were N0 with chemotherapy alone. STO3, it wasn't reported. FLOT, there was an 8% improvement for FLOT, so you did get nodal downstaging, but remember, this includes gastric cancer, so this is a better prognosis group. But on two of the chemoradiation trials, the N0 status was in the 60% range. So 65% compared to 40 to 50% N0 for chemotherapy alone. Why is N0 status important? Well, the rates of pathologic complete response are pretty low for chemotherapy or chemoradiation, and N0 status is also prognostic. Lizzie Smith reported another retrospective analysis of the MAGIC trial in 340 resection specimens. PathCR only 5% for chemo and near PathCR 18%. This subgroup did have a better survival, so response is good, but in the multivariate analysis, the only thing that drove the bus is if you're node negative. So if you're node negative, you do better. PathCR did not impact on overall survival. And I found this particularly interesting that because they had response data who responded to chemotherapy and who didn't. So in the N0 patients, if you were N0 and responded to chemotherapy, your 5-year survival was 60%, 66%. But even if you didn't respond to chemotherapy and were node negative, it was 72%. So it argues N0 status drives the bus, and that response to chemotherapy may not be the be-all and the end-all. So I'm going to conclude that I still think chemoradiation is the preferred approach. Survival is improved for both approaches, arguably no more ECF, either perioperative chemotherapy with FLOT or the cross approach with chemoradiation. The largest series of preoperative chemotherapy alone show really horrendous rates of R0 resection. Chemoradiation is better. Chemotherapy and radiation achieves higher rates of path CR and more patients that are node negative, and N0 status may be more important than response to treatment. That being said, however, FLOT is superior to ECX in all of these endpoints, and we await the phase 3 comparisons, which Eric talked about. But in the meantime, chemotherapy and radiation is the treatment of choice. And these are the randomized trials that are ongoing. Eric mentioned one of them. This is the German trial of FLOT versus cross. But there are 2 other studies that are looking at this comparison as well. Neo-Aegis. This is MAGIC versus cross. Top Gear. This is a preoperative chemo randomization. Patients get perioperative chemotherapy with or without radiation. And all of these trials now have adopted FLOT as the preferred regimen because ECF is inferior. ECF is no longer appropriate to give to these patients. Thanks very much.